Hello, everyone. Welcome to today's webinar. As usual, we'll just take a few moments to let other people join, and then we'll get started. Thank you very much for your patience.
Welcome to this evening's EUROGEN webinar. Just before we get started, I'd like to take a couple of minutes to explain a little bit about what EUROGEN is and does. In 2017, the European Commission created and funded 24 European reference networks, all dealing with patients with rare diseases and complex conditions, so that needed highly specialised healthcare. And we're currently in EUROGEN, we're a network of 56 healthcare providers in 20 member states. And we deal with rare urorectogenital diseases and complex conditions. So they all need highly specialised surgery. So what we aim to do is to deliver quicker specialist evaluation and more equitable access to high quality diagnosis, treatment and care for patients with rare urogenital diseases and complex conditions. So some of our activities, well, we produce clinical guidelines together, and we also have virtual consultations using a secure platform called the Clinical Patient Management System, and those can happen cross-border. They're free to any healthcare professional working in the EU, so please, I would strongly encourage you, if you have a tricky case, please do get in touch with us and we'd be delighted to help. We also do training and education activities together, like this webinar series. And then finally, but very exciting, we have a EUROGEN registry. So we know that the data is often fragmented and scattered all over Europe, really, for patients with rare diseases. So the idea is if we collect data across our network, we'll have the evidence for clinical guidelines and we'll be able to do some interesting research. So without further ado, the title of this evening's webinar is Clinical Burden of Pelvic Pain in Bladder Pain Syndrome and Interstitial Cystitis, a multidisciplinary approach. And it's an absolute honour to have with us this evening three very active members of our network. The first presenter is Dr. Alessandro Giammò. He's at the Neuro-Urology Department of the City of Health and Science Hospital in Turin, Italy. He's head of the Neuro-Urology Unit, and his research interests are in functional urology, bladder pain syndrome, interstitial cystitis, and incontinence. We also have Dr. Mariangela Mancini, who's a urologist, also at the City of Health and Science Hospital in Turin, Italy. And then finally, our third presenter is Dr. Dick Janssen, and he's Senior Research Staff Department of Urology at Radboudumc University Medical Center. And he's also a clinical consultant at the Andros Clinics Center for Complex Bladder Disorders. His research interests are also into IC and bladder pain syndrome, overactive bladder, and urodynamics. So the webinar will be about the clinical burden of pelvic pain, from background to future perspectives, drug therapies, latest developments, and novel and potential upcoming treatments. So thank you everyone for joining, and thank you so much to our experts for being here with us this evening. Thank you.
Good morning and welcome to this webinar on bladder pain syndrome, interstitial cystitis. This presentation will explore the current understanding of bladder pain syndrome, interstitial cystitis, including its pathophysiology, diagnostic approaches, and evidence-based multimodal management. Recent advances in microbiome research, correlations, mechanism, and clinical implication will also be presented to enhance clinical practice and improve patients' outcomes. Chronic pelvic pain is a complex and challenging condition in urology and pain management. It's defined as pain referred to one of the pelvic organs, lasting more than 3 months if continuous or 6 months if cyclically present. It's secondary if caused by identifiable factors such as infections, cancer, stones, and other conditions. It's primary when it's caused by inflammation without evidence of a clear pathology. The pain may be localized to one organ or spread to various pelvic areas. Symptomatology often extends beyond the pelvis, overlapping with other inflammatory conditions like chronic fatigue syndrome, fibromyalgia, and Sjögren syndrome. De facto, primary bladder pain syndrome is a chronic pelvic pain related to the bladder without identifiable factors. The terminology used to describe this condition has evolved over time as our understanding has improved. The International Society for the Study of Interstitial Cystitis, ESIC, defines it as persistent of recurrent chronic pelvic pain, pressure or discomfort related to the bladder, along with at least one other urinary symptoms like urgency or frequency, after excluding the confounding pathologies. The Society, ESIC, has proposed 3 subtypes based on cystoscopic and biopsy findings. The type 1, with a finding of normal cystoscopy and biopsy, but with suggestive symptoms. The type 2, characterized by glomerulations without ulnar lesions, and the type 3, defined by the presence of a ulnar lesion. This is considered a non-subtype, but a distinct disease that corresponds to the classical interstitial cystitis. While the classification is based on histological findings, the clinical symptoms often overlap between these subtypes, making diagnosis challenging. Now speak about pathophysiology and pathophysiological findings. Urothelial defects are a key feature of bladder pain syndrome and are critical part of the pathology underlying the symptoms of BPS. Electronic microscope analysis shows severe defects in the urothelium. Umbrella cells, the topmost layer, show either loss in BPS patients compared to controls and non-ulnar BPS. The umbrella cell surface uroplaque in plaque is significantly disturbed, compromising the bladder's protective barrier. Time junctions between adjacent umbrella cells are also compromised, potentially allowing irritants in urine to penetrate deeper into the bladder wall and trigger inflammation. These structure changes contribute to increased permeability, allowing toxic substances from urine to penetrate the bladder wall and trigger inflammatory responses. Other pathophysiological findings are inflammatory markers and sensory hypernervation. Patients with ulnar lesions demonstrate a significantly high level of inflammatory biomarkers like interleukin-8 and others. And this suggests fundamental differences in immune activation between BPS subtypes, which may require tailored therapeutic approaches. Increased sensory innervation in the bladder wall correlates with the presence of mast cell, indicating a neurogenic contribute to the inflammation and the symptoms. This neurogenic inflammation helps differentiate the BPS from other bladder conditions like, for example, overactive bladder syndrome. Diagnostic cystoscopy is an important tool for evaluating patients with suspected BPS. Two key findings on cystoscopy are urinary lesions and glomerulations. Urinary lesions are hyperemic areas with a central pale scar and diffuse petechiae, indicating a severe inflammation. They are seen in 5 to 60% of BPS patients, with higher rates in those with more advanced disease. Glomerulations are superficial bleeding spots that can cause profuse bleeding and represent an expression of vascular fragility and altered permeability. Glomerulations are not specific to BPS and can be found in healthy individuals as well as and in other pathological conditions. Under lesions identify a distinct disease characterized by severe inflammation with B-cell infiltration and diffuse clonal expansion. The suburothelial and detrusor layers show lymphoplasmacytic cells, stromal edema, and increased vascularity. The inflammation extends beyond the visible lesions, indicating a condition of pancystitis. Patients with ulnar lesions have a significantly high level of inflammatory markers like interleukin-8 and others compared to those with just glomerulations. This suggests the underlying pathophysiology is different between the subtypes. Lower bladder capacity during cystoscopy, that is under 400 milliliters, correlates with more severe acute inflammation, chronic inflammation, and erosion, as well as worse self-report symptoms. BPS is a chronic condition that affects both women and men, with a higher prevalence in women. Recent studies show the global national prevalence is around 0.87%, with women having a higher rate of 1.08% compared to men at 0.66%. Patients often have multiple associated conditions with an average of 2.7 comorbidities compared to 1.7 in the general population. Patients with BPS suffer of common associated conditions that can significantly impact a patient's overall health and quality of life. Irritable bowel syndrome is the most significant associated condition, with over 4 times the odds of occurring with BPS. Chronic fatigue syndrome is frequently seen. Also, fibromyalgia is commonly found, and migraines. BPS patients show either rate of psychosocial factors like alcohol abuse, post-traumatic stress disorder, sexual trauma, and depression compared to the general population. The diagnostic pathway involves a thorough initial assessment, including a careful medical history, physical exam, and laboratory testing. It's important to rule out any underlying urinary tract infections by performing urine culture and complete frequency volume chart to document high urinary frequency and low voided volumes. Next, will evaluate the patient's symptoms, documenting any issues with dyspareunia, dysuria, ejaculatory discord in males, or connection between pain and menstruation in female. We also do a minimal neurological exam to rule out any occult neurological problems. Specialized testing may include evaluating post-void residual to check for urinary retention. If there is hematuria, we'll perform urine cytology and cystoscopy to rule out any malignancies. Also, ultrasound is an important exam. Cystoscopy with hydrodistension is mandatory to define the BPS phenotype. Urodynamic evaluation is not always required initially, but may be considered if we suspect obstruction, detrus or underactivity, or if the patient doesn't respond to standard treatment. BPS can present differently in men and women, requiring tailored management approaches. Men with BPS often face delays in getting the right diagnosis, as they are frequently misdiagnosed with other conditions like prostatitis. This leads to inappropriate treatments and prolonged suffering for these patients. Sexual dysfunction is extremely common in men with BPS, affecting up to 71% of them, and this adds another significant impact on their quality of life. There is a significant overlap between BPS and chronic prostatitis, chronic pelvic pain syndrome. While the pathophysiology may be related, a key distinction is that the BPS specifically involves the bladder, and only 70% of patients meet the criteria for both conditions, suggesting they are two distinct entities. Women with BPS frequently report cyclical symptoms changes related to the menstrual cycle and either rates of painful intercourse. The higher prevalence of BPS in women and its association with other chronic pain conditions are important clinical consideration in women. The treatment approach has evolved over time, moving away from a stepwise model to a more personalized multimodal approach. The last revised guidelines no longer categorize therapy into consecutive steps, but rather classify treatments into broader categories like behavioral, oral, bladder instillation, procedures, and major surgery. A multidisciplinary care approach is now advised, recognizing that there is no single curative treatment and a tailored strategy for each patient's needs is necessary. Initial treatment should typically be non-surgical, except for patients with ulnar lesions, who may benefit from early surgical intervention. These non-surgical treatment options can be an effective first line of defense before considering more invasive interventions. Lifestyle modification like stress reduction techniques and dietary changes are the foundation of conservative management for many patients. Pelvic floor muscle training is indicated in the presence of trigger points and pelvic floor hypertone. Oral medication can help address different aspects of the condition, neuromodulators to inhibit neurological hyperactivity, painkiller for symptom relief, and immunomodulators to address inflammation. Bladder instillation involves directly applying therapeutic agents like glycosaminoglycans to the bladder to help restore the protective lining and provide pain relief. These targeted interventions can provide significant symptoms relief for patients with ulnar lesions. There are several surgical interventions that can be used to directly treat these lesions. Transurethral resection, electrocoagulation for duration, laser ablation, corticosteroid injection. The choice of technique depends on factors like lesion size, location, and physician expertise and equipment. Advanced treatments can be helpful when conservative options have failed. Botulinum toxin injection can reduce pain and urgency by paralyzing nerve endings and reducing inflammation in the bladder. Sacral neuromodulation uses mild electrical pulses to modulate the nerves controlling bladder function. Surgical options like bladder augmentation have high risk and uncertain results, so they are typically reserved for the most severe treatment-resistant cases. A multidisciplinary approach is crucial for managing BPS, as is often associated with other immune-related conditions. The key specialists involved include urologist, that is primary for diagnosis and treating bladder-specific issues, the pain specialist for manage chronic pain aspects using specialized approaches, psychologists to address the psychological impact and helps develop coping strategies, nutritionist provides guidance on dietary modification to reduce symptoms triggers, physical therapist for pelvic floor muscle training. Coordinated care between the specialists can address both the primary bladder symptoms as well as any associated condition for comprehensive management of BPS. What about the future perspectives? Ongoing research into urinary biomarkers shows promise for non-invasive diagnosis and subtyping of BPS. These markers are currently limited to research settings. Development of treatment that specifically address the underlying pathophysiology of different BPS subtypes could improve outcomes. And research into immunomodulation and neuroinflammatory pathways is particularly promising for targeted therapies. Increased focus on quality of life measures and patient-reported outcomes is helping to better understand the real-world impact of treatments. And this is guiding therapeutic decision based on what matters most of patients. And finally, there are the emerging theory of the intestinal bladder axis, that is the role of microbiota. This pathogenetic hypothesis to explain BPS considers gut dysbiosis and increased gut barrier permeability as factors that trigger or perpetuate bladder inflammation through systemic and neuroimmunoendocrine mechanisms. Research explored the interaction between gut microbiota, intestinal permeability, and bladder function. What is the gut-bladder axis? The definition of gut-bladder axis encompasses the set of bidirectional mechanisms that allow the gut microbiota and its mediators to influence bladder function, and vice versa. Of particular significance is the correlation between severity of bowel and bladder symptom, indicating a functional link between the two districts. The rationale of this interconnection is based on several anatomical and functional elements. Anatomical proximity, shared neurological pathways, pro-inflammatory metabolites that are produced by the gut microbiota that reach the systemic circulation and might influence bladder function. And then the phenomenon of cross-organ sensitization, sensitization of convergent afferent pathways, and activation of shared neuroinflammatory circuits. Also, therapeutic evidence indicating a functional link between the two distinct. Intervention targeting the gut microbiota, such as dietary modification, probiotics, have shown beneficial effects on bladder symptoms in subgroup of patients with BPS. Similarly, bladder-directed treatments can improve associated gastrointestinal symptoms, confirming the bidirectionality of the gut-bladder axis. These data support the clinical relevance of this model and its potential therapeutic implication. Macrobiota-based therapeutic approaches represent a promising frontier. For example, probiotics showed efficacy with pain reduction of 25 to 35% and reduction frequency in 50 to 25% of patients. Prebiotics, that are non-digestible substances that selectively stimulate the growth and or the activity of specific beneficial microorganisms, show an efficacy, an improvement in 20–30% of patients. And also symbiotics that are pro and prebiotic combination show an efficacy 50 to 25% either versus monotherapy. There is a famous protocol called Macrobiota Reset, described by Hanno in 2023, that combined approach including dietary modifications, probiotic supplementation, short-chain fatty acid supplementation, and immune modulators. The results at 6 months showed significantly higher efficacy than standard therapy, and this protocol can be enriched by adding complementary therapies that have demonstrated positive effect on the microbiota with polyphenols, omega-3 fatty acid, and vitamin D. Finally, a new frontier, an innovative and promising therapeutic approach for BPS is the fecal microbiota transplantation. Based on the rationale of restoring a balanced gut microbial ecosystem that can positively influence through the gut barrier axis the pathophysiology of the disease. Unlike probiotics, which introduce specific bacterial strains in limited quantities, AFMT allows the transfer of the entire gut microbial ecosystem from a healthy donor to a patient, including bacteria, viruses, fungi, and metabolites, with the potential to induce deeper and more lasting changes in the microbiota. There is a pilot study by Razzi in 2022 that show a clinical response in 60% at 8 weeks and 45% at 6 months, with a significant pain reduction, and the correlation of this clinical response was with an increase of Faecalibacterium that is known for its anti-inflammatory property via production of butyrate and other short-chain fatty acid. To date, there are 2 major randomized trials that are currently underway, that are Reset BPS study and Microic study. An evolution of fecal microbiota transplantation is microbiome-derived fecal therapy, which uses standardized and characterized bacterial consortia instead of whole fecal material. This approach offers significant advantages over traditional FMT, particularly in terms of safety and standardization of composition. The ability to select specific combination of bacteria strain with an inflammatory or immunomodulatory properties represent a significant advance towards personalized treatment for different subpopulations of patients with BPS. A phase 1 study is currently underway to evaluate the preliminary safety and efficacy of this approach in patients with BPS refractory to conventional therapy. Thank you for your attention.
Okay, just going to take a second while we start the second presentation. Thank you.
Hi, everyone. Thanks for inviting me for this webinar. I'm always appreciating ERN giving me the opportunity to talk a little bit about my favorite topic. I was asked to talk you through some novel drug therapies that may or may not be available for Bladder Pain Syndrome. And throughout this presentation, I want to take you to some novelties, but also some therapies that are indicated. Sometimes they're in some guidelines, but not often used. And I think it will be interesting. I've taken out some of them. It's by far not a complete subset of drug therapies or maybe novelties in an experimental stage, but these are ones that I often use or sometimes use in selected cases, and I don't see them often used in other clinics and so on. So I think this can help your patients and improve their management in selected cases and so on. So I'll take you through them. These are my disclosures. And this is the content I will talk to you about. We'll start with an introduction. Again, bladder pain syndrome is a condition that is very much part of conditions that cause chronic pelvic pain. And looking at new guidelines, also at the consensus meeting in North Carolina that has just been there, there is a setting now that we'll do more phenotyping and getting more to grips with the specifics of each individual patient's regarding pain mapping. And all these new guidelines will focus on this very much so in the future, or in the very, very near future. And this will, well, sort of disperse our treatments according to bladder-centric treatments, pelvic-centered treatments, and systemic treatments. And I will focus you on a couple of these treatments to see, okay, this is available. These are therapies that are implemented worldwide, but not so much in Europe. And I want to take you through them and see how we maybe can improve this or improve your use of these treatments in selected cases. Bladder pain syndrome and everything in chronic pelvic pain always seems very, very complicated. And it is not a simple condition to treat, I have to admit, but there's also the challenge. But if you want to keep it a little bit simple, and I think this is very worthwhile because the majority of patients you can actually treat very effectively if you focus on these three main aspects of the disease. So we have our bladder-centric treatments with causes or if you want to reduce inflammation of the bladder wall. There's often secondary pelvic floor dysfunction, pelvic floor pain, leading to all different other organ dysfunctions like dyspareunia, those kind of things, bowel movement problems, and these all contribute to, well, also pain. Your pelvic floor can be extremely painful as a result, as a chicken and egg story from a chronic condition like bladder pain syndrome. And there's also the chronic pain stimuli that can cross sensitization pathway of your pain pathways that also create a more centralized type of pain experience that patients are suffering increasingly from the longer the disease is there. And if you focus your treatments, especially also when you call it the pain and those kind of things, then you get quite a couple of steps further with treatment of your treating your and managing your patients. So I'll focus on these different aspects, and I've just selected some of the treatments that I say that I often use, but are not often used by colleagues, and also maybe some nuance to maybe, well, underappreciated treatments. So again, we know bladder pain syndrome, it's a heterogeneous patient group, and everyone keeps telling it, and it is very, very much true. And that goes for the symptomology, that goes for the treatment results. So it's never one size fits all, and that's very true. So you have to find from this patient due to pain mapping, but also trial and error with treatments to see what works in this individual and go on from there. So it needs rapid or adequate and timely evaluation of treatments. Does it work? Does it not work? Does it cause side effects? Yes or no? And these have to take into account when treating these patients. A step-by-step approach is therefore, because we have this chronic spiral that these patients come in, and they start with pain in their bladder from the bladder wall, and then they end up disrupting their pelvic floor, creating all these other sexual dyspareunia type of problems, bowel movement problems, pain from the pelvic floor itself, and because systemized pain, decreased function, decreased quality of life, psychological dysfunction, all these things. So if you use a step-by-step approach, that's often the road for an inadequate treatment. So I always advise to start mapping all the problems, each individual problem, each source of pain, and or anything of a source that contributes to the pain, and treat each one when possible. And most of the time, trying similar treatments at once is better than just trying it step-by-step, trial and error with one treatment at a time. And this breaks this vicious cycle. These patients are in much more effectively, in my opinion. Well, if you're going to do treatments by pain mapping, I will focus a little bit on bladder-centric treatments, pelvic floor dysfunction and pelvic floor pain treatments, and some systemic pain management. And I'll take you through some novelties in there. I hope to make you enthusiastic about these approaches. So, much often to consider, but not often used, available, or in early stage of development, or in research. So what's all out there? So I'm going to talk about bladder-centric treatments. I want to talk about triamcinolone injections, cyclosporin A or tacrolimus drug therapies, platelet-enriched plasma injections. These are the hot new topics that I confront in when I'm in the general meetings and so on. So let me take a little bit to the evidence. Triamcinolone injections. This is the study from the group from Baldwani and Maldwin, and they actually used triamcinolone injections under general anesthesia, because I heard from experience from Dr. Maldwin that it's quite you really have to inject the triamcinolone within the 100 lesions. It's only also for 100 lesion patients. You can see there's a little imaging there that they inject in 100 lesion with triamcinolone, but it can be quite bloody, so they do not advise to use it without general anesthesia. Also, when there's major blood loss and so on, the better that you actually can use a little bit of coagulation might be needed. The result of these 36 patients, it is a non-randomized, non-cystoscopy controlled trial, so I have to try to say on this, but it is mentioned in the guideline because the effects post-treatment were actually quite severe, or quite optimistic and severe, that they still consider it in their guideline. So they improved quite massively on their pain score from a scale to 0 to 10, a Likert scale was that, and from 8 to 3.8, so that's more than half of pain score. So that was quite significant, and also in the baseline natriuria bar scores, they improved from 7.5 to 5. And I think, especially on a pain perspective, that's a quite dramatic result 1 month after the procedure. Going through the cyclosporin A or tacrolimus, most evidence is there for cyclosporin A when it comes to bladder pain syndrome. Looking from a pharmacological point of view, they are the same calcium type of drugs, and some immunologists and rheumatologists prefer and nephrologists, they prefer the tacrolimus because of, a little bit more manageable side effects and those kind of things. Where does this come in? Because it's quite toxic treatment. They're usually used or reserved for organ transplant patients. But again, it's a very strong immunosuppressant, and there is a niche in there for bladder sparing patients. So patients that do not respond to regular or mainstay treatments like GAG therapy or intravesical installations, or also pentazone polysulfate they do not respond to, and there is still progressive inflammatory leading to worse and worse inflammation, bladder scarring, and functional capacity reduction. That we say, okay, normally what we would often do is just wait and treat symptoms and wait until they're ready for a cystectomy. But there is a window in between. So there is a cyclosporin treatment And this study actually shows that it's still also in the AUA guideline for selected cases. It is a quite severe treatment, but still it can be titrated to quite low doses once stable. And I've seen quite a lot of people responding to the cyclosporin A treatments whilst they were refractory for other treatments. And this has, in my instance and my experience, had some patients that they will not consider a cystectomy anymore because now they have a remission of their Hana lesions and they're doing quite well under this treatment. There is a study from Crescenze in 26 patients. It was a 3-month follow-up, and the results were not actually that good in this treatment. It had some improvement in 31% in the global response assessment, so it's the burden versus the benefits. And again, when but considering that a lot of patients that are unfit or really don't want a cystectomy, there is a window there. It does not remove the fibrosis, so you have to have a window where you do have enough bladder capacity left, flexibility in the bladder wall, to have normal voiding function after you use this treatment. So if you're already a complete bladder cripple, then this treatment is not of use anymore. But there's a window between refractory and waiting for a big patient to become a bladder cripple, and there is a niche for cyclosporin A. There's also some small studies done with tacrolimus bladder installations, but cyclosporin A is in selected cases is recommended in these treatment adversive type of patients, and you can actually save people from cystectomy with this with quite a good quality of life once they do not have too much side effects. And my advice is, when you use this, get a clinical team in there. I use the nephrologist and the immunologists that are more used to handling these patients. So I confer or I collaborate with these specialists because they're more used to these type of drugs, and they need to have quite rigid kidney function control, blood pressure control, and they also have upsetted glucose and cholesterol and those kind of things. So they need careful management because treatments are quite toxic, but compared to people with with organ transplant, they can also be titrated to much lower doses if they are stable on this. So other one is platelet-enriched plasma injections. It's a leukocyte-free autologous plasma mixed with plasma proteins, which is prepared from the patient's own blood. There's in Korea quite a lot of studies going on there, and it would contain all these growth factors that might support tissue regeneration in bladder pain syndrome. It's there is no much good randomized trial. There's 3 non-randomized trial was in the literature review, and in which 55 patients were evaluated with symptom improvement, and it showed promise of symptom relief. But the biggest study out there is from Kuo, and he had a non-randomized patient groups in 98 patients with non-Hana lesion bladder pain syndrome, with 4 monthly intravesical PRP injections, and it really showed quite severe decrease in pain and improvement in functional bladder capacity. But this is not a placebo-controlled trial, so I think we need further trialing with a placebo-controlled trial to see if this is something for our future. But results show much promise. Then I would like to take you through more pelvic-centered treatments. And I have much experience with these types of treatment, and I really hope that people will try to adopt these because these are often quite efficient in getting patients out of this pain cycle. So if pelvic hypertonicity is often present in our bladder pain syndrome cohorts, about 85% on estimate, that is also a chicken and egg, that there is also a pelvic floor hypertonicity and pain problem. And the clear signs of this are often shifting periods of pain, urgency frequency, which is mostly pelvic floor generated, so it's not bladder generated type of urgency frequency, with a sort of persistent urgency to void, often at night, with dysfunctional voiding patterns, dyspareunia complaints, and often a good response to heat challenges like a warm water bottle and those kind of things. And what I, in my experience, find is that alongside lifestyle adjustments, pelvic floor physiotherapy, and pain management, you can try an alpha blocker for 3 weeks to see if that improves. It's very black and white, so it works either very good or it doesn't, people don't respond to it. And intermittent diazepam, 5 milligrams intravaginally. You can wet the tablet, 5 milligram tablet, and place it intravaginally, and it works quite well. There's also an enema, also for male patients with chronic pelvic pain. It can help quite a lot. You have a 5 or 10 milligram enema dose, and in other countries also a sub available. Literature review is divided on efficacy on this, but I do have really good patients with good response to this, whilst they do not respond to much else. Especially when patients have this uncontrollable pain and actually have to report themselves to the emergency department once in a while. That pain is almost, in my experience, always coming from pelvic floor spasms and rarely from a bladder wall in pelvic in bladder pain syndrome. So if they have this and they present at the emergency department, try an enema with diazepam. It works, often does wonders instead of other treatments and so on, and much better than often than opioids. So for centralized pain management, of course, TCAs are one of the mainstay treatments that we give. Nortriptyline, amitriptyline, and the little bit of a brother of it, the pregabalin, and they are really good for neuropathic pain. But many patients come to me and say, well, I tried paracetamol and it does not work ever, and it's not enough, and it doesn't do anything. But we looked at a survey, and to our surprise, it was a survey in 193 patients in the Netherlands. And it was combined with about 50% was patients with Horner lesions, so it's quite a large cohort of Horner lesion patients. But 67% used it on a regular basis. They reported themselves, with 51% reporting benefit from paracetamol. So especially when there's tissue damage, like they have Horner lesions and so on, and there's really clear nociceptive pain, paracetamol and NSAIDs IEDs was also reported to have a 26% benefit, should also be tried in our patients as well. So don't neglect that these can often also help in your pain management. So for a take home, I think it's important that you use pain mapping to see where the pain comes from. It's often multi-site, and try to induce simultaneous treatments for these different sites. So not a step-up approach, but use combinations. It's never a one-size-fits-all treatment, so try to get synergia within your treatments, that they actually contribute to each other. Also the other way around, also be careful that they don't counter-produce results with each other. There are underused treatments or selective treatments available for selective cases, often off-label. Some are really much underused, and they sometimes can be bladder sparing in severe cases. There's also some new treatments with a high potential, but they do need a little bit more evidence. They have promise. Thank you much for listening. If you want to ask me or email me with questions, you're very welcome, and approach me. Thank you so much for listening. Bye-bye.
Okay, it's going to queue up the last presentation. 1 second. Okay. Okay.
So hi, good afternoon. I am Mariangela Mancini, and I'm going to do the final part of this webinar and talk about the surgical options that we have to treat interstitial cystitis. I have no disclosures. Surgical treatment of interstitial cystitis is reserved to the most severe cases and the cases in which we have so-called uncurable bladder lesions, derangement of bladder wall, and permanent structural damage to the bladder, something that cannot be fixed in other ways. And these cases do exist, and the surgery is an effective option for these patients, endoscopic surgery and also abdominal surgery in some cases. Just to explain what I mean by permanent damage to the bladder wall, I just would like to remind you that the bladder is made of several layers. The muscular layer is the most prominent layer. As you can see here, this is a bladder open in front, so we are watching inside. The detrusor muscle, which is very highly vascularized structure, is lined by an internal lining, which is the bladder mucosa, and there is also submucosa under it, and then there is an external layer. And the most important structural changes in interstitial cystitis are at the level of the mucosa and also at the level of the detrusor muscle of the bladder. And if we go back to the diagnostic pathway for patients with interstitial cystitis, you can see that going a little bit down from less invasive to more invasive options, one very important option, and in our experience, probably one of the most important options for diagnosis, is endoscopic evaluation of the bladder in order to get a precise idea of what is the situation of the level of the bladder mucosa, and also a precise idea of the situation at the level of the bladder wall. And this is done by taking a deep biopsy of the bladder wall. European guidelines recommend biopsy under general anesthesia as deep as possible in order to get all the layers of the bladder wall and have a pathological examination. And the lesions that we can see in the bladder have been classified into 3 degrees, limited lesions, glomerulation, and Hanner's lesions. And these are the most severe lesions that we can have in the bladder. So cystoscopic evaluation of the bladder is very important to understand the level of severity of the disease. And although there are no specific requirements or tests which are required for the diagnosis of interstitial cystitis in the guideline, however, we know that in the vast majority of patients, there is a severe bladder inflammation with infiltration of immune cells in the bladder muscle, and at the mucosal level, we can have severe impairment of the mucosa with loss of the barrier function of the mucosa. So this means that urine can infiltrate the bladder wall and get into the deeper layers of the bladder, and this is a very destructive event. I'm showing you some images of endoscopic evaluation of the bladder, which were provided as a courtesy by Dick Janssen, and these are cases in which you can see several possible cases, different cases, like we can go from vessel thickening, widening, and glomerulation in less severe cases. We can go to Hanner lesions, which are inflammatory plaques, thickening of the bladder wall with the possibility of mucosal tearing and formation of ulcers and infiltration of urine in the deep bladder wall, and also hemorrhagic areas inside, as you can see here in the D picture, hemorrhagic areas inside the ulnar lesions. Here is a severe pancystitis with inflammation of all the bladder wall and also Hanner lesions. Here you can see contraction, severe contraction of the bladder wall with the Hanner lesion and contractions converging into it, and also we can see hemorrhagic events during cystoscopy and hydrodistension, and bleeding, active bleeding during the examination. So what can we can hypothesize that these areas where the bladder mucosa is dying, is eroded, could be resected, could be removed in order to improve symptoms of the patients. And this is actually true. And this is a case, in my experience, a very severe case of interstitial cystitis with severe symptoms. And what I found, you see bladder wall contracture, Hanner lesions with hemorrhagic areas inside, and also the late events of inflammation, which is calcification of the tissue, which has been growing around these areas. And you can see here these two lesions which seem like this. They were on the bladder neck and they were causing excruciating pain to this patient. And this patient had tremendous improvement with resection of these areas and the thermocoagulation, tremendous symptomatic improvement. To show you just here what is the level of destruction of the bladder wall that is possible in some cases of interstitial cystitis, I'm showing you two images of electron microscopy examination of the bladder wall. These were studies, classical studies done in the 90s with electron microscopy at the level of the detrusor muscle, samples taken from deep biopsies of the bladder. And this is a normal smooth muscle cell with a regular cytosol, with a regular nucleus. And here on the right, this is a cell, smooth muscle cells taken from a patient with interstitial cystitis. And you can see vacuolization of the smooth muscle cells. You can see chromatin margination, a prominent nucleolus, condensation of the cytosol. So all aspects which are pre-apoptotic aspects, and they can lead to complete loss of smooth muscle cells at this muscular level. And these are terminally differentiated cells, just like the mucosal epithelial cells. So these cells will not be replaced, but they will be substituted by connective cells, by fibroblasts. And this will lead at the end to contraction of bladder wall and reduction of bladder volume, bladder capacity. Here, just a curiosity, you can see the cellular membranes of these cells, which are so deranged, so irregular. They've been shown to be similar to the maple leaves. And so this is a typical pathognomonic ultrastructural sign of pre-apoptotic stage in muscular cells in the bladder. More recently, similar changes of destruction, of apoptosis, of necrosis, of another phenomenon that is called anoikis, which is detachment of the epithelial cells. Similar signs have been seen in the mucosa, and so not only in the muscular layer, but also in the mucosal layer of the bladder. And you can see that the cells sort of die and detach from the mucosa and detach from the bladder, so they fall inside the lumen, and so urine can infiltrate the deep layers of the bladder. And in some studies, this phenomenon has been shown to be reverted by the use by injection in the bladder of platelet-rich plasma during endoscopy. And this has been mentioned also by Dick a few minutes ago, and this is a very prominent strategy which is just now coming into more attention. So injecting plasma of the patient enriched with his or her own platelets into the bladder can reverse the apoptosis and necrosis at the level of the bladder mucosa. Look at this higher magnification of the same samples of before. These are the epithelial cells dying and detaching, you see, from the deeper layers, falling inside the bladder. And this is what happens at the ultrastructural level after injection of platelet-enriched plasma. So this is an incredible effect, which could reverse some of the final stage phenomena of this disease. So endoscopic management, surgical endoscopy, so general anesthesia, biopsy, possibility of injection, possibility of diathermocoagulation, possibility of taking samples for pathology. All this is very important, and not only to confirm the diagnosis of interstitial cystitis, and not only to because there is a strong correlation between findings at histology and symptoms, not only to exclude other conditions, so for differential diagnosis, but also to reduce symptoms. And this is the new idea, the new strategy, work on the inflammatory plaques, work on the deranged bladder mucosa by resection, by diathermocoagulation, by injection of substances like platelets that are taken from the patients, or we could hypothesize stem cells or other growth factor which we could inject in the bladder. So in order to obtain reduction of symptoms for the patient. So treatment with surgical endoscopy and not only diagnosis. And so going deeper into these treatment possibilities, after endoscopic treatment, you see there is surgery. And surgery is sort of has been considered for a long time the last step. So when there is nothing else that works, and when we have tried everything, and this has been the traditional approach, even though this can be discussed, we can this is not definitive, but surgery for sure is one of the possibilities that we can delay as far as possible. And as Dick has mentioned now, for example, cyclosporin A treatment is one possibility of delaying surgery or avoiding it. But there are there are cases where surgery is unavoidable to improve the quality of life of the patients. And here I put this image, is a painting which a patient, a man with interstitial cystitis sent me, and it's the way he represented his pains, like a flame that was covering everything else in his life and was really making his life miserable. And these are the cases where everything has been tried and there is no relief. And these are the cases where we can offer surgery to the patients and see an improvement in their situation. I just would like to say a few tips for when we talk about surgery, abdominal surgery for interstitial cystitis. So cases in which patients have to be involved. So discuss with the patients, talk about their expectations, talk about complications of surgery, talk about possibilities of surgery, and always find an agreement with the patients before going to surgery. Another key point of surgical approach to interstitial cystitis is experience. So surgeons who go to do these things have to be experienced with abdominal pelvic surgery, with cystectomy in particular. And if they are experienced, and this is very important point, in this case, we know that if the indication is correct, surgery is a safe and effective measure in selected cases. And which are these cases? So are the cases with significant untreatable symptoms. And when I say untreatable, I really mean it. Significant untreatable symptoms. Cases with loss of bladder capacity due to severe scarring, and as I said before, replacement of smooth muscle cells with fibroblasts, with connective tissue, with severe fibrosis, and so reduction of bladder capacity and loss of the bladder ability to function as a low pressure reservoir. And in these cases, when we get to a small bladder, when we get to reflux of urine into the high urinary tract, we can also get impairment of kidney function, and these are cases where surgery is absolutely indicated. Which are the procedures that are that we can choose? So procedure is basically cystectomy, which can be total cystectomy, or also subtotal or supratrigonal cystectomy. So, which means basically to maintain the bladder neck and the ureters in situ without reimplantation of the ureters. In this case, we might need a replacement, cystoplasty with ileum, or when we do total cystectomy, we have to two possibilities. We can do an external diversion, so incontinent diversion, like a uretero-ileocutaneostomy, or we can do an external continent diversion, which the patients can self-catheterize, like the Mitrofanov procedure, or we can do an orthotopic neobladder. And uretrectomy is not often required, and this is something that can be discussed with the patient unless there is an absolute involvement of the urethra in the inflammation process with severe impairment of the anatomy of the urethra. Uretrectomy is not usually necessary. The traditional thinking about surgery for interstitial cystitis has been that an external diversion is better than an orthotopic neobladder. Although this has been proposed for a long time, more recent data suggests that this dogma can be discussed, and an orthotopic neobladder can be a very nice and acceptable alternative for women and for men with this situation. I'm just going to show you two recent studies. This was presented at the American Urological Association a few years ago. It's a study of analyzing the data of 25,000 cystectomies in California in the last years, and of this 0.1% were done for interstitial cystitis, so a very small number, with a complication rate very high, 62%, but with, as the authors point out very clearly, done by surgeons with limited experience in cystectomy. So, and this is a very important point. A strong association has been found also in this study between complication rate of cystectomies done for interstitial cystitis and surgical volume of the surgeon, of the operating surgeon. Other studies, recent studies of cystectomy for selected cases of interstitial cystitis, like a Japanese study, have shown good pain relief and improved quality of life. Also here down below, a German study, high satisfaction rate and long-term limited complication. Like this is an interesting follow-up of 171 months. So very good long-term outcome. But I would like to point out this as a recent systematic review of more than 400 cases of cystectomies for interstitial cystitis, which is a very high number considering that it's a rare event in a rare disease. And this study has shown symptoms improvement, significant improvements, and high patient satisfaction in 95% of cases. So the highest number when the patients had received a neobladder rather than an external diversion. So this is a study that is pointing out that a well-done neobladder can have a very high satisfaction rate in the patients. Despite this data, despite these indications, of course, there is not black and white solution. So there are no randomized trials on surgical treatment of interstitial cystitis. So we have to keep this in mind. The data are based on reviews, on experience of experts, and what we can have in this rare situation. But we know for sure that the best approach is the approach that provides the best quality of life improvement and symptom reliefs to these patients. If orthotopic neobladder is well done, this procedure can offer a very high satisfaction rate to the patients. But let's have no dogmas on this field and keep in mind that there is no one-size-fits-all approach in this case. Always remember that the patient has to be involved in clinical decisions, and patients' expectations have to be taken into strong account, keeping always a flexible mindset but remembering that surgical experience of the operator, of the surgeons, is key for success in this situation as in all other situations where when a cystectomy is required. Take-home message, as I said, I repeat it, involve the patients in surgical decisions. Remember that this is challenging surgery, and surgical experience of the operator is key for success. And we must remember that a cystectomy done for interstitial cystitis can be very challenging because it's a deep, strong inflammation of the pelvis, and so dissection planes can be very difficult, and we need to do a very good job. So we need experienced people to do this. Experienced people means surgeons experienced with cystectomies, with abdominal procedures. Surgical care should be centralized in center where the experts are, and this is even not enough. It's ideal to connect these centers in international networks where experts can exchange opinions and ideas. This is basically what our network is doing, and so this is very appropriate for us to do this inside a network, European network. The last thing, we recently as a network published this book on rare and complex urological conditions, and is a very valuable source for all these severe and complex diseases, just like interstitial cystitis. And in this book, we have written a chapter we are very proud of, me and Dick Janssen and Alessandro Giammò and other authors, and we have put in this chapter a lot of information and experience and an extensive literature reviews, and you can find here all the things we said today and much more, so I invite you all to read it. And with this, I thank you very much, and I'd be happy to take questions if there are any. Thank you.
Okay, that's the end of all the presentations. Thank you to the presenters for doing those for us. So I'll just ask the presenters to come into the webinar now. We're a little bit over time today with the presentations, but if anybody's got any questions now they'd like to ask, please do so now. I've noticed a few come through immediately. Before we answer those, just a reminder to everybody who's attended today that you will get a notification about the survey to fill in after this webinar. You get that via pop up straight away, but you also get a notification by email. If you fill that within 2 weeks, you will get an accreditation certificate as well. So just let you know that. Okay, please. I don't know who wants to deal with the questions that have come through.
Can we talk directly, Darren? So...
Yeah, please go ahead. Just
okay. So I read the first question. Does radical surgery make sense for a patient who already has centralized neuropathic pain? And there is also a second question. Can BPS-IC exist in a patient with a clear neurological diagnosis? Okay, very nice question. I try to answer the first one. So it depends if the pain is the only symptom, and this patient has a regular bladder with regular upper urinary tract, and only pain as a symptom. I don't think cystectomy can make sense. This is my personal opinion. So the indication for cystectomy are different than pure centralized neuropathic pain. So in this case, I think it wouldn't make any sense to do a cystectomy only to treat the pain, because the pain may not be treated with a cystectomy. A cystectomy has different indications than this one. This is my opinion. I don't know if my colleague want to.
Yeah, I agree. I only advise cystectomy when there is really continuous inflammation, bladder cripple situations, those kind of things. I think the route, and also if you do a cystectomy on patients with just neuropathic pain, so no real normal bladder capacities, the outcomes of your cystectomy will be far worse because they most likely will keep on having pain. So I'll be really reluctant to start that, and I will much more go into generalized pain management with pain clinics, with neural blockages. But still, if there is some inflammation and those kind of things, still I would do anything to quiet the bladder down with GAG therapies, with benzoyl polysulfate, everything you can do, and a trial and error. But cystectomy will often, I think, in my opinion, in these patients with a more poor quality of life outcome. So select a patient, and it is really continuous, uncontrollable, non-responsive to treatment type of inflammation and continuous bladder crippled situations.
Okay. And the second question is, can BPS IC exist in a patient with a clear neurological diagnosis? Do you want to answer also to this one, Dick?
Yeah, well, I've seen every type of combination, also a lot of autoimmune diseases. That's also very common. Is you have the inflammatory type, the Hunter lesion type, and so on. So be aware, and also in my experience, just a little bit different, but as an advice, if they have secondary autoimmune disease like Crohn's disease, rheumatoid arthritis, and so on, make sure that those are treated well as well, because in my experience, if you have an other active autoimmune disease that is not very well controlled, the treatments that you do for your bladder pain syndrome to reduce inflammation also often do not work very well. So it's an inflammation that's flaring up of your immune system. So also the other parts of your body needs to be treated for that as well. But when you look at a clear neurological diagnosis, I've seen it all. I've seen Hunter lesions in spinal cord patients and so on. I've seen it after different types of trauma. So I would not rule it out. Basically do cystoscopy and see what's going on in there. And if you see clear signs of inflammation, Hunter lesions and so on, then you will have some bladder-centric phenotype as well. And you can treat for that as well. So just see where it all comes from. But the most common mistake I often found, and that is something that's very more common in neurological diagnosis like multiple sclerosis and so on, is the confusion with just pure chronic pelvic pain due to pelvic floor hypertonicity. The difference really is for bladder pain syndrome that you have pain during bladder filling. And when it's mostly, and that's something that you can ask for, if it's pain mostly after voiding, that's mostly after to pelvic floor type of pain. Those are the ones that respond to diazepam, and it can be very confusing because often they sometimes have some erythrocytes and some leukocytes in their urine, but that's mostly because of the urethra closing down too much and causing mild inflammation there. And bladder pain syndrome by itself is not a urethral disease; it's really a bladder disease. But the secondary pelvic floor problems are more prone in that can happen simultaneously, but it can also happen individually in other patients due to other reasons. And that's a common mistake that I get a lot of referrals for patients that have referred to me with bladder pain syndrome, and they do not have bladder pain syndrome, but they have pelvic floor hypertonicity and pain, which leads to dysfunctional voiding and a similar type of pain. But the nuance is different. One is with bladder filling, that's a bladder pain syndrome, inflammation of the bladder wall, and the other one is pain by the pelvic floor. And that often happens with multiple sclerosis and so on, with spasms of other muscle groups and so on. So make sure that you differentiate the two of them because it can be quite tricky. So ask for heat responses when the pain occurs. So not during bladder filling, but more after during voiding or after voiding. Those kind of things can make the difference in nuancing the differences.
Okay, great. Very nice. Okay, then we have a question. What is the best meeting to go to learn more? You mean to learn more about interstitial cystitis? Well, there is the ESIC meeting.
Yep. It will be upcoming in Milan in September.
September 2025.
And I think that's a really good focused meeting. And there are some new things coming up. There's a new guideline coming up And it's quite broad, much more focused with flowcharts, how to treat your patients. So it may be just more useful than just a standard list of things that you can do. And in the last part, there's also just been a consensus meeting in Wake Forest in North Carolina with also some consensus documents on, and they sort of also follow the same path or ID that the ESSEC guideline will also be, but it's more really pain mapping type of treatment. So bladder-centric, pelvic-centric, generalized pain, so you can have more focus on what to pay attention for. And if you know, okay, this is what I need to pay attention to, then you also know the treatments for all these different things, and that can help you. So, but best is to learn just to go to an ESSEC conference like that. So it's really specialized on bladder pain syndrome management. So you're very welcome.
Great. Then we have more questions, but I don't know, Darren, if can we answer? Or
It's up to you if you've got time.
yeah, sure. Yeah,
it's fine because we could just
okay. Then we have it. Thanks, and you're very welcome. Actually, if you have more questions, you can email us, and we will be happy.
There was two questions here I see at the bottom. So is there any role
for outpatient?
Hydrodistension, yeah.
Hydrodistension.
Okay.
Outpatient, what do you mean? Outpatient without anesthesia? I don't know exactly what it means. My personal opinion is that I would do hydrodistension under general anesthesia, and I think I don't know, Dick, if you agree, but I think there are two kinds of hydrodistension. Hydrodistension that is done with the therapy as a therapy to increase bladder capacity. And I remember when I was a medical student, there were some patients who came into the clinic and did that with a measurement of the pressure inside the bladder, and they did graduate filling of the bladder. And I don't know, then this has been abandoned over the years, and I've never done it. And I personally don't do this anymore. I think it would be damaging to the bladder wall and even impair the patient's ability to urinate after. But another thing is like quick hydrodistension when you do a cystoscopy for diagnosis, like you fill in the bladder while the patient is sleeping, and then you immediately remove the water, empty, if you do like a quick emptying, and then you go inside with the cystoscope and look. And there, I think this can increase your ability to see glomerulations or to see bleeding from lesions inside the bladder. And I think this can be valuable. And I must say that what I have seen in patients with interstitial cystitis is very different from what I see in other patients. So I saw there is a question down below that says that every patient has glomerulations with filling of the bladder. I don't agree with that. I personally don't see them. You can see sometimes in heavy smokers or patients with CIS, but what you see in interstitial cystitis is much more typical. I think this is my personal impression.
In the new guidelines also, and also the current guidelines, therapeutic hydrodistension is not recommended to do or to perform. I think it's like scratching a mosquito bite. It's maybe it gives a very short-term relief, but it actually harms you in the longer term. Because you do cause microtrauma in already a fibrotic inflammatory disease. I mean, it's still recommended you can do this to discover new Hana lesions or maybe subtle Hana lesions and so on. But it will be done under general anesthesia, because otherwise it will be very painful. I'm always quite reluctant to do this, because sometimes when I see inflammation and I see an Hana lesion, I don't need to distend the bleeding. I don't need to cause extra bleeding. I try to be as less invasive as possible. So only when I question or I doubt, then I would say that hydrodistension gives me added value for my diagnosis. So I don't do the standard in every patient.
Okay.
Then there was a question on if there were any viral origin insights. And there were, I think it's 1 or 2 years ago, there were some interesting studies in it on Epstein-Barr virus and polyoma. BK virus is really something different.
So BK or CMV-induced cystitis, there will be a new ERN guideline coming up for inflammatory disorders. These are the BK and CMV type of cystitis is more associated with post-stem cell transplantation patients. So it's quite typical for that type of and almost exclusive for those types of patients where it occurs. But the Epstein-Barr type there was some interesting reports, but I haven't seen any follow-up on any evidence since then. So it's fallen a bit of a silent death, but it was an interesting paper actually. And it was quite a large cohort that they presented this in, but I think it needs follow-up experiments or cohorts to confirm this, if it's regional or it's, but so far, the current diagnosis that for Hana lesions, there's clear signs that it is an autoimmune type of response, with plasma cells being much more defined than the mast cells. And the non-Hana lesion is not an inflammatory disease. It can have inflammation, but it's not an inflammatory disease like Crohn's disease or those kind of things. So these things we do know now. So that's what makes type 2 very different from type 3 from that perspective, even though they're very similar complaints.
And also, I would like to add on this that there are these interesting electron microscopy studies that I've shown some images, and electron microscopy is a very good way to look at viruses, and in many of these studies there is no evidence of viruses inside the bladder wall. So morphologically this has never been proved, but it's an interesting hypothesis. But as Dick said, I don't think we have any evidence that viruses are responsible for Hana lesions. Okay, then we partially answered to that. It says that glomerulations are induced by hydrodistension itself. At some point, yes, but not always. I think sometimes glomerulations are there even before hydrodistension, don't you think, Dick? So they can be there anyway.
It's not specific, and indeed hydrodistension can cause bleedings and micro trauma and so on. So it might not be ruled out. So I would not say, okay, you got glomerations after hydrodistension, that's specific then for type 2 bladder pain syndrome. I would rule that out. So glomeration will just be visible once you do the cystoscopy before the hydrodistension. And it's not specific. I do think it's important to note down that it's having glomerations. On the majority of cases, there is other signs of inflammation as well. The vascular thickening and the torqued vessels and so on. These kind of things, they are quite specific for type 2, and they're also visible often in type 3 bladder pain syndrome. And I do think these will give you an option for bladder-centric treatments. So you can, we know how inflammation works. We know how you see inflammation. And so if you see clear inflammation that goes inside with the pain symptoms that they have and the symptoms of bladder pain syndrome, then I think there's room for trying bladder-centric treatments. And I think that's the most important one, because sometimes they say, well, there's no Hana lesion, so there's no inflammation, and so we don't use bladder-centric treatments. No, there's also other types of inflammation that you can see without Hana lesions, and they can also respond to intravesical gag therapies.
And they can respond, Sometimes I also see glomerulation and thickening of vessels in heavy smokers. Like, for example, you can see something similar, even though in the bladder of interstitial cystitis, they can be more severe. It's a more severe thing. Anyway, they are all signs of inflammation. Probably sometimes it's worth to take a biopsy and see what's inside. Anyway, this being said, we have this on the posterior fornix syndrome. We have a newly proposed phenotype, posterior fornix syndrome, the result of neuroinflammation from the visceral plexus displacement. Any thoughts on this? It's possible.
I think we're not there yet. The ESSIC made a proposition to have different subtypes. Well, we know we know that type 2 does not transform into type 3, so they're really two different entities. But now also with the pain mapping, we tend to, in the guideline, go much more for the phenotyping part. So, and these phenotypes can mix. You can have bladder-centric plus pelvic-centric, bladder-centric plus centralized. So these are all mixes and matches, but they will confirm you to a treatment direction. I think that's the most important one. And I think when it comes to different, more subtypes, they will probably be there. Because there's also some rarer cases. I've seen also within discussions, like sometimes there's some rare cases where there's 100 lesions found in the ureters and so on. So I don't think we have stratified every single subtype there is in bladder syndrome. But I think it's already difficult enough at this moment, and it's rare enough at this moment, even for 100 lesion patients, that we need to have some consensus on how to target these patients. But the field is ongoing in this. So also with molecular diagnostic, GWASs and so on, to see if there may be some subgroups in there. Also, when it comes to treatment responses, so that we actually need to learn, okay, why does this group do respond to types of treatments and this group does not? So we need to find out this a little bit more. And everyone who contributes to this is good, I think.
Great, yeah. I agree that it's already difficult enough. Now we have a comment from the Italian Association for Interstitial Cystitis saying that the meeting will be in October on 23-25. So this is Milan, right? Okay, great, we said this. Okay, and this other question, if we don't distend the bladder to find the volume, how do you identify them when volume starts decreasing so we can start immunotherapy, for instance?
Yeah.
Well,
I have many discussions on this. Sorry, Mariangela, I'm talking. Do you want to respond to this?
No, go ahead.
With colleagues, there is no set guidelines. You can say, okay, this is the true anesthesiologic measure on anesthesia and so on. With a hydrodistension, you can say, okay, this is then my measure that I take. I look at my patients and I use my frequency voiding charts, and because that's what they actually can contain in their bladder. So if they're doing worse and worse and worse, then their bladder will probably be also their voiding capacity, their functional voiding capacity will also be lower, lower, and lower in time. So and that's much less invasive than doing a hydrodistension every single time. And when you start immunotherapy, for instance, is when you can see that that all your things that you're doing, there's still ongoing inflammation, and you can look at, you can do a qualitative assay on a cystoscopy to see that this is an ongoing fibrotic type of bladder. And I combine it with my voiding diary, and I have patients measure at the same time, mostly beginning of the day, having their and don't do a whole day long voiding charge, but just a regular in the morning void to see what their capacities are, and that gives me a trend in time to follow these patients up. And I think that's more accurate with their daily lives and symptomology than doing it all on hydrodistension. But I have colleagues that really disagree with me on this, so this is my opinion.
Yeah, no, I agree with you that a diary done by the patient is really not invasive, and I find it very useful. But yes, so also you can have an idea of bladder volume also by doing an ultrasound with the full bladder, or you can do urodynamics, of course, once in a while, not very often as a bladder diary. There are many different ways to have an idea of what is your bladder capacity without doing another distension. Then we have a question on Sjögren's disease. Sjögren's is an inflammatory disease. If you have IC BPS with Sjögren's, you would imagine that this is also inflammatory, or not?
Yeah. You want to take this? I can take it.
Yeah, I think it is possible. I wouldn't have a specific answer to this question, but it might be an inflammation involved.
The large study done in Japan, in Tokyo, by Yoshimura, do show that the non-100 lesion group does have a very distinct profile regarding that it's 100 lesions really correlate to what you see in autoimmune type diseases, with the types of immunoglobulins that are upregulated in autoimmune diseases, and it was not found in large groups of non-100 lesions. there is this line, and I think there's between autoimmune and atopy, like allergy and so on, and especially that allergy type of reaction, that's still very unclear in the mix, because also autoimmune diseases correlate often with atopic disease like asthma, eczema, those kind of things, and so and that's very unsure. So it might be that there's a factor in there. We don't exactly know, but we do know that Hanna-Lesion disease is very much correlated to an autoimmune type disease response, whilst then the non-Hanna-Lesion is not, but that might be more an atopic type of immune. So we really don't know exactly, but that might be a correlation with the Sjögren's disease or other autoimmune diseases that we can maybe understand. I mean, if there is no infections whatsoever and there is inflammation, then there is something going on with immune system. And there's an atopic disease like asthma, there's also something going on with the immune system. So there might be a correlation there, but that's still something that we need to find out more.
Yeah, interesting. Yeah, very nice. So this is a very interesting question. Why do we know so much about BPS-IC in theory, and yet we are so ineffective in clinical practice? So first, I say two things only, Dick, then I leave it to you. So one reason is that a lot of patients do not get proper treatment and do not get somebody who is knowledgeable about this disease. This is one reason, but also sometimes even if you get a good expert, you still suffer. And I would make an example. Make an analogy with cancer. I mean, we know a lot about cancer. We know, as compared to 20 years ago, we know everything about DNA, oncogenes, tumor suppressor genes, and tumor DNA, but still people die of cancer. So this does not mean, the fact that we know a lot of things about something does not mean that we are able to treat it. And the same thing with interstitial cystitis. I think we know today a lot more things than 20 years ago. And for example, what Dick said about novel treatments like plasma-derived platelet-enriched plasma injections. This is a very innovative thing that we didn't know 5 years ago. So I think we are going there. It's a process. I mean, we are in the process of, and we are growing. And I'm sure in the next year we will do better. I mean, this is really a growing field. Difficult and growing, so I'm hopeful. I don't know, Dick, if you agree with this.
Yeah, and in my experience is, well, I've been a resident. I have a specialized clinic where we treat these patients, and if you have the time and to really work up these patients and really do the proper pain mapping, you get somewhere. I would have given up this whole field if I was not helping my patients.
Yeah.
You do have to understand that it is often a chronic disease if you have bladder pain syndrome, and like other chronic diseases, like you have Crohn's disease, rheumatoid arthritis. There is always, it's a chronic disease, so you have to help them be get them the best quality of life. But if you take all the aspects that can cause pain besides the bladder, and manage all those different things, you can get a lot better with these patients. You can get them a lot better than when they come in from a quality of life perspective. But you need to focus on really identifying all the things that contribute to their pain, and it's often too easy just to focus on the bladder. There's always more going on, and you need to treat that too. And if that's forgotten, then you will just be stuck with these patients because they will relapse. They will not improve in the quality of life. So think a little bit more broad besides your own specialty. And think also on gynecological problems, like if there's like a sclerosis, think if there's bowel management problems, treat that as well, because all those things also work on the pelvic floor, and the pelvic floor is often involved as well. So get the pelvic floor physiotherapies in there and try to treat that as well. All these things will get you a much better result and very satisfied patients. If you because if it would not be able to do that, I would have given up a long time ago. So. But that's it. You need time and dedication, and also some patience to explain to these patients what's actually going on, because often they are really convinced that it's only the bladder, whilst maybe the pelvic floor is much more dominant in the pain complaints. So you need to make them aware where their pain comes from, how they should treat it, how should they respond to these types of treatments, what they do with their lifestyle and so on. And then it comes quite, I mean, I have more problems with people with chronic prostate pain type of problems than a bladder pain syndrome problems. These are much more difficult to treat and have much more relapses. That's how I think on this whole field. So.
In fact, some of the most suffering patients are men, as the painter that sent me the painting that I show you, he was a man. And so I think men are even more complicated than women for some aspects.
Yeah.
And I just would like to say that it is really incredible. Sometimes you see a desperate patient which has been treated years before, and you see him or her, and you can make him better. And this is an incredible feeling. I don't know, Dick, if you can share this with me. And this is what keeps us going, because otherwise we would have left years ago. So this is what keeps us going, when we can see these patients so desperate and we can make them better, because most of the time we can really help them. So
we as doctors also need some positive feedback, and if we get that, and we get that from the patient, trust me. And but it takes time, so they take more time than a regular patient with an OAB problem and so on. But if you take the time and you put in the effort, you get results. That's my that's really is my experience.
I agree with you.
I think we're about done with the questions, aren't we?
Yeah, we are done. We got some compliments, and then thank you all. It was great. And if there are more questions, we are here.
Yeah, thank you for taking the time to answer all of those. Just a quick note: Dr. Giammo was going to join us for the Q&A, but unfortunately he was called to the operating room, so he sends us apologies.
Okay.
So yeah, to say a quick reminder to everybody: fill in the survey. We'll send out the link to the recording tomorrow to all the registrants. That'll go onto our YouTube channel as well, so please check that out and subscribe if you haven't already. There are quite a few other webinars on there already dealing with bladder pain syndrome and interstitial cystitis, if you haven't seen those already. Yes, so thank you to everybody for attending, and thank you also, a massive thank you to our presenters tonight, to Dick and Mariangela and Alessandro as well. So thank you all three of you. I don't know if there's anything you wanted to say to finish off, and then we'll end up with this. We'll finish off.
Okay, thank you.
Thanks everyone. Thanks for listening and taking your time in the evening. I hope to see you soon somewhere in a conference.
Yes. See you soon. Ciao.
Bye-bye.
Yeah, good evening. Bye-bye.